Hi everybody. I hope you can all see and hear me. I'm sure somebody will let me know if I'm speaking to myself. So welcome to tonight's virtual event. This one is called Paths to Parenthood. And my name's Catherine. I'm the lab manager at Care in Nottingham. I've worked for Care for 24 years. So during that time, I have seen so many changes and so many exciting changes and leading to increasing success in making families. It's quite amazing. So this event, I shall be giving you all the information you need to get to parenthood. And then at the end, we'll be answering questions. So I'll be going through diagnosing a fertility problem, an IVF treatment pathway, treatment with donor eggs, sperm and embryos, the lab techniques that we use to help improve your chances of success, the support at Care, funding your treatment, and getting started at Care, which will be a video from our patient inquiry team leader, Shah. So the whole package, hopefully. And then there'll be a questions and answers session where I'll be joined tonight by Dr. Tony Rutherford, who is the medical director at Care Leeds. So you can ask questions throughout the evening in the private questions tab or in the public chat where just your first name will be visible to everybody on the event. Or you can save your questions and send them via email to events@carefertility.com. If we don't have time to answer your question during the event, we will send a reply via email. And if you think of a question after the event, our patient events team will reply as soon as they can via email. And also the patient inquiry team are available until 8 p.m. this evening. And that's on 0800 564 2270. And then at the end, we will wrap up with a message from our CEO about life at Care and our dedication in supporting you on your journey. So to begin with, I'm just going to give you a short video to introduce you to Care.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are Care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Okay, so actually 1 in 6 couples need help in starting a family. So you're not alone, and we are here to support you through it. So at Care, we have 14 clinics all around the country, and each one has experienced and expert clinical teams. So no matter how complex or simple a treatment may be, we can guarantee there will be someone in the team who is specialised in the area and can help make the difference. So during tonight, I will be referring to the general IVF process, but whether you have treatment with your own eggs and sperm or with the help of a donor, the principles are the same. So it is really easy to get going with Care. We have a new patient inquiry team who are very knowledgeable and can answer all of your questions about getting started and about the treatment. The team are also, as I said, available until 8 p.m. this evening to answer your questions in the questions tab. So, getting the right diagnosis is the key. And we take the time to get to know everything about you before you start, including a detailed medical questionnaire. And all the information is reviewed by one of our consultants prior to your initial appointment. Each patient will get set up a secure online patient portal for all information related treatment in one place. So you can upload previous medical notes and test results onto the portal for live viewing. In your consultation, your fertility specialist will listen to your fertility plans and wishes, explain your test results and the need for any further tests and why these are necessary. They will discuss the different treatment options and each one's chances of success. You will be given detailed information about the treatment options to consider in your own time, and you will be provided with a cost estimate and given all the time you need to ask questions. So after the consultation, you will have an idea about your individualised treatment plan and what it consists of. This may not be IVF in the first instance. It could be IUI or fertility medication. However, tonight, because the majority of treatments involve IVF, this is the journey that I'll be discussing. So IVF. It starts with ovulation stimulation. This is prescribed medication to stimulate the ovarian follicles to produce eggs. So you'll be given a medication protocol by the nursing team, who will explain to you how to prescribe the medicine and also support you in following the protocol that you're given. There is also an online injection teach video to remind you and to follow along at home. Whilst you're taking the medication, we will be monitoring the follicles by ultrasound to find the correct time to collect the eggs. The monitoring phase usually lasts between 7 days, sorry, not 10. And once you're ready, you'll be given an injection to trigger ovulation. And at that point, you'll have your egg collection 36 hours later. So the egg collection itself is a straightforward procedure. It's performed under ultrasound guidance in our theatre, where a needle is guided into the ovaries and extracts eggs from the follicles. This is usually performed under nurse sedation and lasts a maximum of 30 minutes, followed by a short rest, time for a cup of tea and a biscuit, and then you're ready to go. So during the sample is usually given at the same time as the egg collection. And we can collect sperm via minor surgery if there is an issue in collecting sperm from a sample. So this is an analysis of a sperm. So during the setup of your treatment, you'll be asked to provide a semen analysis so that we can tailor the treatment to the amount of sperm that you have. So the analysis looks at sperm concentration, the number of sperm, the motility of the sperm, if it's moving and how it's moving. As you can see in the video, there's different types of movement, and these are monitored and tracked. And the morphology of the sperm, and that's how each sperm looks. So its head shape and its tail structure. So this allows us to build up a picture of whether the sample will be suitable for IVF, ICSI or IUI. So, as I said, the eggs can be fertilized by either the IVF or ICSI. So IVF is where the sperm is put into a dish holding the eggs, and the sperm is allowed to enter the eggs naturally. ICSI is where a single sperm is injected into each egg, and this is the equipment that injection is done on. So the method of fertilization is decided before the egg collection, but our embryologists always check the egg and sperm quality on the day, just to ensure that everything is okay for the planned treatment. So it could be that if we found less sperm than we expected on the day, and you are having IVF, there's no need to worry, because we will just revert to ICSI as a treatment. So on the day after the egg collection, the embryologists observe the eggs, and then they can tell if they are fertilized or not. So a fertilized egg looks as the top left picture here. It's got two nuclei within it, one from the sperm and one from the egg, and that tells us that they've both gone through the fertilization process. The embryologist will ring you in the morning after they've checked the eggs for fertilization and pass on all of this information to you. We will discuss how we expect the embryos to develop and explain when we expect the embryo transfer, biopsy or freezing to be. We will also provide detailed information about the expected embryo development and put that on your patient portal for reference at any time during the treatment. But this picture shows the stages of development. So the first one being the fertilized egg, the next one beside it being a 4-cell. And then if you go to the bottom on the left-hand side, you can see an 8-cell embryo. And then at the end, you can see what we call a blastocyst. And this is where the embryo has differentiated. So it has an inner cell mass, which is a clump of cells in the middle, and outer cells, sphere-like outer cells, which are called the trophectoderm cells. We know that not all embryos do become blastocysts, and that's normal, but this is where we would expect them to be on day 5 of the embryo development. I don't think my video is working. Oh, thank you. So this is a developing embryo. So it's going through all those stages of multiplying, becoming more and more cells. Then the stage after that is where all the cell walls start to compact together. And then as there's a fluid-filled area and all the cells go to the outside of that, the zona, the outside shell of the egg, becomes thinner and thinner. And then eventually that inner cell mass and those trophectoderm cells will hatch out of the shell of the egg, and that needs to happen for it to implant into the endometrium in the uterus. So this is another procedure that we can offer, and it's called PGT-A, which is where we test all the chromosomes within the cells. And this is where we take the blastocyst and we take a biopsy. A blastocyst has hundreds of cells within it. We need about 5 to 7 of these cells to be able to test. So not a very small proportion. And that's a procedure called biopsy that we do in the lab to remove those cells. This isn't for everybody, but it gives you an extra layer of information about whether your embryo is chromosomally normal. We are also have procedures, tests that we use, which are called SOS and Care Unity. And a technology that we're particularly proud of is our care maps. Which is back to this slide. So this is an embryoscope, and the embryoscope is a time-lapse incubator, which allows us to build up a video of embryo development, and using the technology to compare in-house embryos that have produced a live birth and those that have not, we've been able to build an algorithm which we call Care Maps. This ranks embryo development to help us select the embryo for transfer with the highest chance of producing a live birth. We're also very, very excited to present our latest in-house AI technology in tandem with the success of the Care Maps, whereby AI is used to investigate and interrogate and record the development of the embryos and then apply the Care Maps algorithm. So it's learning all the time how to become better at annotating those embryos and looking at them than we can in the lab. So the embryo transfer process, this again happens under ultrasound guidance. However, there is no requirement routinely for sedation. The embryo is loaded into a soft and fine catheter and inserted through the vagina into the cervix into the uterus. It takes about 15 minutes at the longest, and there's no requirement for rest afterwards. After that, it's a 2-week wait until your pregnancy test. The care nurses will be on hand throughout this time to give you guidance and support. And we know it's a difficult time. You will start progesterone. This aids the implantation of the embryo. And if you have a positive test, you will have a scan at care, and at that point be discharged into the care of your GP. If you have a negative result, you will be supported by the nurses, and the counsellors are always available, and we will arrange a follow-up consultation for when you're ready. So there are many different reasons why you might need to use donor eggs, sperm or embryos. And our donation teams have over 25 years experience and have helped more people to start a family with the help of a donor than any other UK clinic. And they will support you throughout the entire process, from initial questions through to helping you to select your donor and specialist counselling that's required. At CARE, we believe that support is an integral part of the journey for patients. We want you to feel supported and safe, and the process in itself is stressful enough. So anything that we can do to minimise that, we want to do that. So every team at CARE is developed to provide patient support in their areas, and that is to ensure that there is support available at every moment of your journey. And we also have free counselling appointments. These can be done face-to-face or online or over the phone. And we have CARE social media and a 24/7 CARE online forum for you to chat with other patients, so you never have to feel alone. So we're here to support you medically, emotionally, but financially as well. So CARE Pay is an exclusive, individually tailored IVF funding package designed to give patients a financial peace of mind, knowing that a plan is in place to fund your treatment. We've created CARE Pay following patient feedback that it is disruptive to have to contact someone else to access your funding programs. So CARE Pay is managed entirely in-house, so the patients can have seamless experience. And again, your treatment is personal and private. So all the CARE Pay programs include cycle monitoring, egg collection, all the embryology procedures, unlimited embryo transfers, freezing and storage, and care maps is also included as an extra benefit. Okay, so thank you very much for listening, and we'll be moving on to the questions and answers section. So don't forget, you can ask questions in the chat or questions or via the email, again, at events@carefertility.com. So now I'm going to introduce Dr. Rutherford in person, and he's going to help me to answer some of your questions tonight.
Hello.
Hello. Hi. Right. So have we got some questions to answer?
We do. Would you like me to answer, address some of the questions that we were asked for? Okay, so somebody who is on this webinar this evening mentioned that they had a low sperm count and they wondered what they should do about it. What should happen next? Well, the first thing to do is that you need to get it repeated, because we want 2 samples rather than 1. If you have done, then we'll move on to the next stage. But the reason for doing 2 tests is that a man's sperm count can vary. Even in supposedly fertile men, if you did a sperm test twice a week for a year, there would be times where the values fell below the normal range. So, you know, there's all sorts of things that could affect it. And a prime example, for example, is a nasty viral infection like COVID could knock it down. It might improve afterwards. If you have a nasty cold or cough, that can also have an impact. So, you know, look at your history, what's happened. And that's why when you do have an unexpected result like that, it's best to leave it for 3 months before repeating it, because the sperm take 84 days to make. So repeating it too soon, you might not get the right answer. Look at your lifestyle. Is there anything in there that you're doing that could potentially be affecting it? Are you someone that has a really hot bath every day, or go to the sauna twice a week, where you're cooking your testes and you're cooking your sperm? And sperm like to be cold. That's why they dangle outside the body. So make sure you wear loose-fitting underwear. It is important, and it does make a difference. Think about your diet and what you're eating. And don't think that saving up your sample and repeating it, leaving it for 10 days and then testing it again is going to make a difference, because actually the longer you leave it between ejaculations can actually lead to deterioration in the sperm sample too. If you've got 2 persistently low tests or really, really low tests, then you need to have some hormone tests done and try and work out what's going on. And so once you've had a basic hormone profile, to look at the hormones that control sperm production, to look at the male hormone testosterone, that sort of level, and to look at your thyroid and your prolactin function, because that too can affect fertility. If you're taking particular medications, go back to GP and say, well, look, should I be on this medication? I want to try for family, I've got a low sperm count. Does this medication have an impact on my sperm count? So there are lots of things that you can do just from your history. And then there are investigations that your GP can do. And then you can send you to see us in clinic, because there's lots of treatments that we can do. This fantastic treatment Catherine's talked about that was developed back in 1992 called ICSI radically changed what we can do for men. Before that came about, we could treat about 13% of male factor infertility. Now we can treat 87%. It's a massive, massive change. Makes a huge difference and gives couples that in the past would have had a chance, a real good chance of having a baby. I hope that answers your question. Now, Catherine, how do you want to handle this? Because there's a few others.
There's lots, isn't there? Yeah. So I've just seen one about implantation failure and what could be a reason for implantation failure, or the reason. So this is something that we can answer together, because I can answer from the lab side of it. So one of the reasons for implantation failure would be because even an embryo that looks amazing, that has developed to a blastocyst, is hatching out, may not be chromosomally normal. So as I explained before, our care maps, it will rank an embryo So these are embryos that have become blastocysts and are suitable for transfer or freezing. But there may be something that's happened in their development which has lowered their chance of becoming a live birth. So we rank the embryos from 1 to 10, with 10 being the strongest embryo most likely to create a live birth. And an embryo could look exactly similar to that, but be scored a 1, which has a much lower chance. So obviously we choose the highest grade, the highest ranking embryo for embryo transfer, but that may not be a 10. So that would be one thing. We'd be able to have a look more closely at the ranking of your embryos and get more of an idea of your chances of success. And then obviously embryos develop really, again, without any differences in their appearance, but they can be chromosomally abnormal and therefore have no chance of implanting. And there are a very small percentage of embryos that are chromosomally abnormal that will implant. But most of them will then go on to become a miscarriage. So that's 2 reasons in the lab for it.
So from a clinical perspective, Catherine's told you about the passenger. I'll tell you about the passengers. You. Basically, there can be some issues. Now, even if you put back a chromosomally normal embryo, the maximum chance of implantation leading on to an ongoing pregnancy is only 70%. So it means there's at least a 30% chance of it not working because of a procedure-related failure. Now, it could be that there was an issue with the embryo transfer. Sometimes the uterus can contract and it doesn't like to be irritated, and it may contract, and that might help push the embryo out. It may be that the little hairs on the cells of the lining of the womb, the endometrium, they can move an embryo around a little bit, and it may fall into an area which is not favorable for implantation. Occasionally, if you have got damaged tubes, it can go upwards into your tube. So that can happen too. But there's also rarer problems, and it could be that that your implantation window is not quite right. That we know that 66% of women, the right time to put the embryo back, if it's in a frozen embryo replacement cycle, is on the 6th day of your progesterone treatment. But we also now know that in 29%, it needs to go back a day later. In 5%, it needs to go back a day earlier. So there is a test that's been developed. It's called an endometrial receptivity assay. And what that does is it looks at 244 RNAs, which are the messages for making proteins that code for implantation. And it works out when is the best time from that and where you fit, so they can modify you so you can have a personalized transfer date. Now, does it work? It sounds a little bit sci-fi. Does it work? Well, there have been some trials, and the people that developed this did divided people into 3 groups. They did IVF and a fresh transfer in 150 people. They did IVF and froze all the embryos in a frozen transfer in 150 people. And they did IVF, froze all the embryos, did a personalized transfer based on the ERA result. Who came out top? The ones that had the personalized transfer had a 10% increased chance of getting an ongoing pregnancy compared to those that had the fresh. And then the third in line was the frozen. If you looked at every single embryo that was created in that stimulated cycle, the overall cumulative conception rate, putting them all back, was 20% greater in the ERA test results group. So it's not a massive trial, it's 450 patients, but it certainly shows a potential interesting reason why it might not work. They've combined that with another test, and that's your endometrial microbiome. That's a fancy term for saying the bugs in your genital tract. We've all got bugs all over, and a lot of them do us some good. And certainly the bugs in a lady's vagina do good. There's a really good bacteria called lactobacillus, which uses the glycogen made from the vaginal wall cells to make acid, which keeps the vagina a really acidic place, and that prevents nasty pathogenic bugs from growing there. But in some women, it may be related to their diet, it may be related to their immune system, their defenses aren't quite as good, and that gives the opportunity for more pathogenic or invasive bacteria to grow. And in a smaller proportion, they are in the womb and they cause chronic inflammation, a low-grade chronic endometritis, inflammation of the lining of the womb. You wouldn't know you had it. And actually, if you stuck a swab in there to try and find out, that would come back negative because the concentration of bugs is so low. But this particular test, by looking at your endometrium, they actually look, modern DNA technology, look actually at the DNA of the bacteria, and they can tell you what's in there. Can you do anything about it? Yes, you can. We can give you specific antibiotics, we treat that infection, and then we give you vaginal probiotics in the form of a pessary to repopulate the vagina to put back the natural defense mechanisms. So that's something that you can do. I seem to have frozen on the screen. Is that...
No, you haven't frozen for us.
All right. Okay. I've frozen on my screen. Okay.
So I've got another question, which I think is more in line for you to answer. Recently diagnosed with perimenopause at the age of 40. What would you recommend?
Okay. So first of all, if you've had the tests again checked more than once, so you know that these are really, it is something that is absolutely happening. And when the test that we're looking for is a raised FSH, so that your FSH hormone is high, and it's higher than your LH hormone. That and often in these circumstances, you have a low estrogen. In those circumstances, it is best to seek medical assistance and help. Most of the fertility treatments that we have aim at increasing your FSH levels to make more eggs. Where you've got a very high FSH level, those treatments are not going to work. And if the FSH level is that high, it is likely that you may need some help with egg donation, which gives you a really good chance of a baby. But it's unlikely with very high levels of FSH that are persistent, that any form of fertility treatment like IVF or fertility drugs would actually work.
Thank you. So I've had a question again about the care maps, and so I shall go into a bit more detail about how it works and how it actually improves the selection of the embryos. Before we had the time-lapse incubators, our method of looking at the embryos developing was in the standard incubator. We want to keep embryos in their natural environment for as long as possible and as much time as possible. So we would get the embryos out once a day, every 24 hours, and we'd have a look at them and see how they were developing. So over the course of 5 days, we would look at them 5 times. So we knew that on day 2, they should be 4 cells. On day 3, they should be 8 to 10 cells. and then by day 5 that they should be blastocysts. And that was the extent of the information that we had about the embryos. Then along came the time-lapse incubator, which took a picture every 20 minutes of the embryos developing. And so we built up a video over those 5 days. And what we realized, which was amazing at the beginning, was so much information that embryos do funny things throughout the days and nights when we're not looking at them and taking that snapshot view of them. And so, as I alluded to before, what we did was we built up a library of those embryos that had created a live birth and those embryos that hadn't. And we compared them to see every little thing, how they developed differently. And out of that, with some very clever statisticians, came an algorithm, which is used to rank the embryos, as I said. So an embryo that develops in a way that is more likely to cause a live birth, to those embryos that are more likely to, that have caused a live birth, then they will get a 10, a ranking of 10. So that's one of the reasons why the Care Maps has improved our pregnancy rates or our time to live birth. The other one being that we are no longer taking those embryos out of the incubator at all. So they go in after they have fertilized in the case of IVF, or after the injection in the case of ICSI, and then they're only removed again once the embryo transfer or the freezing is about to occur. And we know that that obviously is where they want to be, and it's where they're the happiest to develop. So we have also, because we still do standard incubation, but we have done something that we call do not disturb, which is where we have learned that there's no real value to the information that we get between day 1 and day 5. So the best thing for the embryos is to keep them in the incubator for that time. So we no longer do those snapshot visuals of the embryos. And that actually has created an increased pregnancy rate in our standard incubation patients as well. So if you are having standard incubation, we have applied all of our knowledge that we can to that as well, to enhance the results. So I think we've got one last question. And this is, does a vasectomy impact on the quality of sperm? It's been 20 years.
I certainly feel that if you've been had a vasectomy that long ago, that it is likely that trying to attempt a vasectomy reversal is unlikely to be successful. But you could conceive by having a sperm collection and then doing the ICSI process that Catherine described earlier. A man that gets older, men are a bit like sperm factories, and they continue to make sperm throughout their lives. But as they get older, maybe the mechanisms get a little bit rusty and maybe don't make quite as many, but they still are able to produce sperm that are capable of fertilization. When you get a sperm from a vasectomy, where somebody's had a vasectomy, you aim to collect it from the outside of the testicle in the collecting system called the epididymis. And the sperm may not look great when you collect it, you may not get great numbers, but it's usually good enough to actually fertilize eggs and form babies with exactly the same sort of fertilization rate as we would get in other men having other forms of IVF treatment. So the fact that it was done 20 years ago doesn't mean that he couldn't conceive through the ICSI process, but he wouldn't really be a candidate for vasectomy reversal. So if you had your vasectomy 5 years ago, you might attempt a reversal because that might be worthwhile. If it's 10 years, that's the limit really. But above 10 years, I think a sperm collection procedure and then IVF with ICSI will give you the best chance of having a baby.
Perfect. Okay, so I think we'll wrap it up at that. So thank you. We'll leave you now with our video of Shah, our patient inquiry team leader, and also our CEO with a few words.
I'm Shah, and I manage CARE's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose CARE was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of one size fits all, but with CARE that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to CARE.
Oh, the support at CARE was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared for by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists, and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.